Good afternoon and good morning wherever you are calling in to join us today. Welcome to the afternoon session. This is our Antimicrobial Awareness Week webinar, and the session that you're joining us for today is the regional approaches to capacity building and training for antimicrobial resistance. And I'm very excited to be chairing the session. My name's Kirsty Buising. I'm an infectious diseases doctor working in Melbourne, Australia, and I am one of the co-leads of that AMR theme, that antimicrobial resistance and healthcare acquired infection theme at the Doherty Institute. And there's a big picture of the building that the Doherty's housed in on your screen at the moment. So before I begin, I'd like to acknowledge the traditional owners of the many lands upon which we are all residing today while we meet via webinar. And I'd like to pay my respects to elders of the traditional owners groups, past, present and emerging. So the purpose of this webinar today is to bring together a broad range of speakers who work across the Western Pacific region, particularly supporting activities to prevent and manage antimicrobial resistance in the region across both human and animal health. And I'm very excited because I think there's been a lot of terrific work happening in the last year in this space, and we've got to know a lot of people in the region who are now collaborating on projects, and we're going to talk a little bit about those today so that you can start to hear about the fabulous work that's going on. In terms of talking about the structure of the sessions, each of the speakers is going to deliver their talk, and then we'll try to save time just for one or two questions at the end. And so if you do have questions for the speaker, if you could try to pop them in the chat box, and then if I can see them, I'll ask them on your behalf, and you know, stimulate a little bit of discussion, I hope. So on that note, I think we may be able to move directly to the first talk, and the first talk is mine. So I'm very excited to be talking to you a little bit about what we've been doing, or the activities that we've been participating in through the Doherty Institute. And I guess, if you'll indulge me, I'll move to the next slide. So where I was looking to begin this talk is, I think we all know what antimicrobial resistance is, and we're all very familiar with a lot of the figures that are on this slide about the impact it's likely to have globally, the numbers of deaths that we predict will be attributable to antimicrobial resistance each year over time, the expectation that number is growing, and the strident calls that are being made for us to really be taking action in this space. And I think anyone who's signed into this forum will appreciate that this requires global coordination. AMR is clearly not a problem that can be managed in silos. So we all appreciate that antimicrobial resistance is a threat to our ability to treat common infections in humans. It's a threat to our ability to treat common infections in animals, and it's a threat to efficient agriculture and therefore food safety for populations. And as we've stated, it's going to require public health action at a global level to manage it. Just struggling, let's see if we can move forward. So in our region, I think just to begin, it may be worth acknowledging that our understanding of where antimicrobial resistance is at the moment is somewhat limited, and primarily the limitations come from there being poor quality of available data and lack of coordination and correlation of data. And in addition to that, there has been inadequate research around what interventions work and which ones work, particularly in the settings in which we're working. It's important to acknowledge that antimicrobial resistance has a disproportionate impact on people who are living in low and middle income countries due to a myriad of reasons. But I think we can all think through the high burden of infections themselves in some communities is important. Reduced laboratory infrastructure to permit diagnoses to be made or to allow surveillance of resistance amongst pathogens to happen. Limited diagnostic testing more generally, so that there's a lot of empiric use for things that may not even be infections. Limited regulation on the use of antimicrobials, and we're very familiar in human health with the problem of over-the-counter access to antimicrobial drugs. Limited regulation on antimicrobial use in animal health is a significant problem. And then that's coupled with poor infection control that permits high transmission rates once drug-resistant pathogens are present, and even the major problem in a community problem of crowding, which again permits easy transmission of pathogens. And then thinking about prevention, we need to, I guess, include some aspects like poor access to vaccination and other things that might work to help limit the need to use antimicrobials and thus contribute to antimicrobial resistance. But I don't want this to be a negative slide, and I thought it's really important to say with all of that, it's important to say that we've got a lot of enthusiasm. We've got great emerging leaders who are ready to collaborate, and I think there's real promise in us achieving something meaningful in a reasonably short time frame in our region, for a number of reasons. But I really just think the right people are coming together, and there are some real investments and dedicated effort happening in this space that I'm very hopeful is going to lead to some fruitful progress around these limitations. And I'm going to talk to you a little bit about some of those. So with this talk, I'm going to tell you about 3 programs that we've been involved with at the Doherty Institute. I very much appreciate that many of you online may be involved in many other projects, but I'm just speaking to the ones that I know. I'm going to talk to you a little bit about the Combat AMR program funded by the Department of Foreign Affairs and Trade at the Australian Commonwealth Government under the Pacific Infectious Diseases program. I'm going to talk a little bit about the Fleming Fund Fellowship program, which is funded by the Government of the United Kingdom. And then I'll tell you a little bit about a brand new project that hasn't yet started but is about to, funded by the Medical Research Future Fund, which again is the Australian Commonwealth Government within the global health program sphere there. And the project is around tackling critical AMR pathogens in Fiji. So to start with the first one, Combat AMR, and to acknowledge the many people who are part of this consortium. It's a very large program that involves a number of partners. The Doherty is leading it, but we are by no means doing this alone. The project is around working together to combat antimicrobial resistance in Pacific Island countries. And as I've mentioned, the Pacific Infectious Diseases Program is funded by the DFAT Centre for Health Security, with the aim of this program to mitigate infectious diseases threats. The end of program outcomes, so what we are looking to achieve with this program is improved surveillance of infectious diseases and treatment resistance in pathogens. And the project duration is 2.5 years long, and it did actually start during 2020. And as you might imagine, we've obviously had some significant impacts with unexpected challenges from COVID-19 with this project. But Combat AMR will implement training, mentorship and capacity building programs to improve infection prevention and control and surveillance of AMR pathogens, and to improve our ability to prevent and respond to the threat of AMR. And the Combat AMR program will work with clinicians, infection control practitioners, pharmacists, scientists, microbiologists, veterinarians, and policymakers across a number of across selected Pacific Island countries. These are the project partners. And we're very excited to work with some really dynamic and terrific people from many of these groups. And many of them will be familiar to you, but the Asia Pacific Centre for Animal Health is largely coming from the Faculty of Veterinary and Agricultural Sciences at the University of Melbourne, Massey University in New Zealand, WaterAid with the water and sanitation programs, which is an important component of infection prevention and control. The Burnett Institute with terrific background in developmental programs and global health initiatives. We have clinicians from the Alfred who are providing terrific subject matter expertise. PREDA, the Pacific Region Infectious Diseases Association, and again, clinicians with a long history of work in nominated Pacific Island nations. And we have the Pacific Pathology Training Centre based in New Zealand, but again, many years of history in working with laboratories in particular in the Pacific region to enhance their capacity there. And finally, the Brigham and Women's Hospital in the US with particular expertise in AMR surveillance. These are the countries that we're working with, and so Fiji, Samoa, Papua New Guinea and the Solomon Islands. And importantly, we should say that much of the learning that we develop on the programs that we develop over these 2.5 years, our intention is to make that available more broadly across the Pacific region, but the focused intention of the work initially is in these 4 countries. The project aims are, we have 4 main themes within the project. The first is infection prevention and control, and it will be focused on improving those systems within major health facilities. Largely, it's the key national referral hospitals in each of those countries that we'll be focusing on. Improved antimicrobial stewardship, again, that will focus on the major national referral hospitals in the country. Improved capacity for laboratory surveillance of AMR, and this will focus on the major hospitals and in addition the national public health laboratories in those countries. And the 4th theme is the animal health theme. So again, using a One Health approach, improving the understanding of cross-sectoral surveillance across human and animal health. And this, I guess, graphic describes how the 4 themes, infection prevention, antimicrobial stewardship, lab capacity and animal health, work across the 4 main countries that we're working in. And it's important to acknowledge that this is an area where there are other actors, there are other groups who are working, and we're needing to collaborate, work with existing projects that are happening in countries. So as an example, the CSIRO from Australia are already doing some work in animal health in Fiji, and so we're working to make sure that what we do fits in well with those groups and doesn't create difficulty for them. And in Papua New Guinea, the Fleming Fund, which you'll hear about in a moment, is doing work in 3 of the themes. So that's meant that we've scaled back some of the activity that Combat AMR is doing in those areas in that country in particular, just to avoid overlap. I will take this opportunity just to flag some of the theme leaders and thank them for their work. So in infection prevention and control, many of you may know Andrew Stewardson and Lindsay Grayson, who are working to lead that theme. Antimicrobial stewardship, Dr. Tricia Peel is working there alongside myself. Lab capacity and surveillance, Professor Ben Howden and Adam Jenny. And animal health, we have Glenn Browning and James Gilkison in particular are working there alongside Joanna McKenzie from Massey University. So the project principles are it's very important with these projects that we coordinate with the existing national AMR action plans and work alongside and with the national AMR committees in those countries. We will engage with the country counterparts at the national sites, ensure that we coordinate with other national and regional activities that might be being conducted by key groups, and you'll hear from some members of those key groups in a moment. We're endeavouring to ensure that always we're working cross-sectoral with a One Health approach. And at the commencement of this activity, there's a comprehensive situation and needs assessment being done to properly define what the best project activities are and to identify the appropriate professionals for the training. there is a train-the-trainer model in place, and we're working to build relationships across the region. So the idea being that if these 4 countries are using common tools, have a common understanding of how to deal with and talk about AMR, and that we build collaborative workshop opportunities for these people, these leaders to come together, that you know, we'll build that key nexus of enthusiasm and sustainability going forward. So for the first 6 months, we were a bit diverted due to COVID-19, and the team from Combat AMR did provide very targeted support to those 4 countries in accord with their needs, so at their request, providing laboratory support for diagnostic testing and infection control support to ensure preparedness for managing patients with COVID-19. Now that we're moving into the main Combat AMR project activities, and it's really starting we're starting to get an opportunity to focus in on what we originally intended to be doing. The infection prevention and control stream is working on hand hygiene production in country, hand hygiene program implementation in hospitals, infection prevention and control policies and procedures in hospitals, and looking at water and sanitation and hygiene. The Antimicrobial Stewardship Group is looking specifically at auditing, reporting, how to develop policies, procedures and guidelines for hospitals. The lab team are looking at diagnostic testing and surveillance, and the animal health team similarly are looking at surveillance of antimicrobial resistance and surveillance and understanding of antimicrobial usage patterns amongst animals. Here's some photographs of some of the work that's already being done, funded by the Combat AMR team. So in Papua New Guinea, with the support of the Burnett team, alcohol-based hand rub production in country is already being set up, which is a terrific advance, and I think something that many have been endeavouring to have happen for some time. So that's really taken off quite quickly, and it's very exciting to see progress being made. In terms of the implementation, what are we currently doing right now? For many of the countries, we are through or nearly through memorandums of understanding with the local governments. We're just about finished employing our in-country project coordinators so that there are people on site to help manage the relationships for us. We are establishing collaboration and coordination with the national AMR committees, so just to target those key people. And then the next steps will involve engaging with the key national hospital and laboratory staff, identifying and coordinating with whatever existing or planned AMR training activities are going on, and as an important early step, conducting the situation and needs assessments, but we're having to do that remotely because we can't physically go and do it in person ourselves. We're identifying the champions for training and mentoring, developing work plans in collaboration with the counterparts, and developing plans for monitoring and evaluating the whole program. Moving quickly to the Fleming Fund Fellowship Program and telling you a little bit about that. This is named after Sir Alexander Fleming, as many of you would appreciate. The Fleming Fund is funded by the UK government, and it has several parts to it. We are working in this red wheel, the fellowship program. There are country grants, regional grants and global grants that are focused on different aspects of building capacity around managing and better understanding antimicrobial resistance. So the Doherty's role is in the fellowship program. The fellowship programs support professional development of practitioners across human and animal health to help them develop skills, receive mentorship, and provide opportunities for peer-to-peer knowledge sharing and learning. The fellowships are on-the-job training programs, so our fellows have jobs in their own country and they keep doing those jobs, but they're freed up, their employers free up some of their time to be working on the fellowship. So the Doherty is a host institution, and for each of the fellows there's a beneficiary institution, that is the place that they work in, and we are matched up, and there's an agreement that takes place between those two groups on what sort of work the fellows will be undertaking. So here's just a graphic of the aims of the fellowship activities, and as you'll see, as well as mentoring the individuals, we are looking at building networking and collaborating, and strengthening the institution itself. So the mentoring team from the Doherty and involves, importantly, the University of Melbourne Faculty of Veterinary and Agricultural Sciences people as well. And we've been matched to the fellowship program in 4 countries. And we're conducting fellowships that run between 18 and 22 months. And we're working with Bhutan, Nepal, Papua New Guinea and Timor-Leste. The fellowships, I think we've kind of mentioned this, but the objectives very clearly are to improve use and interpretation of data around AMR and antimicrobial usage, to improve One Health collaboration, including the design of a collaborative project between the fellows in different streams, and to contribute to capacity building in the institution itself, so that there's a professional community of practice across the One Health domain. And here's some example. We're currently mentoring 28 fellows across 4 countries. I think the last time I looked, the whole Fleming fellowship program worldwide had just over 100 fellows. So we really are taking on a significant proportion of those that are funded. And you'll see the names of the different types of fellowships that people are undertaking. So each one of these blue squares is one of our key people who we're mentoring. To implement the fellowships, these fellows actually apply for the fellowship, they're interviewed and selected, and then we travel across and conduct an opening workshop in country, visit the beneficiary institutions, look at where they're working, meet the people who supervise them, and together we develop a work plan. And then there's some desk-based face-to-face training at the beneficiary and host institutions. So when travel is permitted, that absolutely happens. When it can't, we find other ways to be face-to-face, like via Zoom. The teams are developing collaborative projects, and the projects, all of the work plan and the projects need to be approved by the UK government. So there's quite significant oversight on what we're doing. But as you'll appreciate, what it's done is opened up terrific opportunities for regional and international networking and professional development. And many of our fellows are, starting to take part in and actively contribute to, in really fabulous ways, some international conferences now that they're starting to gather data and have really meaningful and important findings to share. So I'm going to share with you some photographs of what happened with some of our, this is from Bhutan, when we went over and conducted our initial visit, our in-country workshops. These are the mentors and the fellows all together. This is one of the workshops we conducted, developing the work plan. And then we visited people in their workplaces, so some of the laboratories, to see what they were doing. And equally, the Bhutanese fellows had the opportunity to come back and visit us in Melbourne, and I think they spent 4 weeks with us. And I think these are some of the fellows back at the Doherty working with our team and learning hands-on about the type of work that we do here. And here's Courtney and some of the data that's been presented at conferences. In Nepal, similarly, the workshop with the fellows and the mentors here in Kathmandu, and you'll see how we really work through, break down in detail the pathways of how pathogens are handled and where the information is available and where we've got missing information and what we might do to build capacity. In Timor-Leste, again, the mentors and the fellows there, terrific smiling faces of everybody, and workshopping through with the fellows what their work plan might be. And finally, in PNG, the fellows and mentors here as a big group, and some visits out to the hospital and to the laboratories to actually see the physical spaces where people are working and what they've got access to and what the needs might be. There's a new type of fellowship starting soon, which is called a policy fellowship. It's a new category, and 2 fellowships have been confirmed in Bhutan. They're only 12-month fellowships, but they're likely to be really impactful, we think. So the objectives are to assist the national AMR coordination committees, promote strong leadership and vision to help further develop the national AMR action plans, They will work on raising awareness in the national political and sectoral leadership areas on AMR to advance integrated evidence-based policy development across the sectors and to assist in building communities of practice again amongst the Fleming Fellows. And the very last slides I've got here are about the last project to mention. This is the MRFF project under the Global Health Initiative called Preparing Fiji for Pathogens with Critical Antimicrobial Resistance. So the objectives of this are to support research to enhance knowledge and develop tools that will enable us to combat the threats to national health security posed by regional and global challenges of AMR and to foster international research collaboration. So the aims of our particular project were much more targeted to look at Fiji specifically, and we were looking to pick pathogens with what we called critical antimicrobial resistance and to think through how they specifically might be detected and how the hospital might respond and manage those. And so two of the important bits we're drilling down on are to assess the role of genomics to inform infection prevention and control activities and to look at the practicality of implementing that in the local healthcare context. And then to assess how a structured training program for healthcare workers and key decision makers in managing people affected by these specific pathogens will best lead to improved preparedness. So there's really an advanced laboratory aspect and an advanced infection control aspect. And you can see that it builds very well on a lot of the basic work that the Combat AMR program will do. And this will take it to another level. I won't go through this slide in very much more detail, but really it drills down to the more specific aims and objectives from each of the components. We're still in the early development of project plans at the moment. It will really kick off early next year. And importantly, we're needing to coordinate with the Combat AMR and any other AMR projects that are currently going on in Fiji, just to make sure that we don't confuse the space, but instead that we work collaboratively. So I'm going to finish there. I hope I haven't gone over time. No. But to acknowledge and thank the many people who've had a hand in those projects. And I'm happy at this point to take questions from anyone. I'll stop sharing now and just have a look and see. If anyone has any questions, I'd be delighted to take them in the chat function. If you, otherwise, I'll give you a few minutes. I guess it's really just a very broad overview there. Otherwise, I might just finish and say I'm very happy for anyone who's interested in learning a little bit more about the projects to contact me or any of the team at the Doherty, and we'd be happy to share a little bit more information with you if you're interested. If there's no questions, I get the exciting opportunity now to introduce you to one of our fellows from Papua New Guinea. And I think I'm delighted to introduce Judith Nui. And Judith is the AMR Secretariat for Papua New Guinea through her role at the National Health Department. She manages the National Antimicrobial Resistance Committee and technical working groups in AMR. And Judith is also the Fleming Fund AMR Advisory Fellow in Papua New Guinea. And I have the great pleasure of being one of her mentors, and it's been a terrific experience already. And Judith is working on projects that are specifically related to policy development and advocacy around AMR. So it's a really interesting fellowship that looks at how you communicate with the community and how you communicate with policymakers and how you keep AMR active on the agenda. So it's been a really exciting and interesting program for me to be involved with, and I hope Judith has been enjoying it too. So Judith, I believe we've got a video that you've taped for us that the team are going to share. Is that right?
Kirsty.
Yeah, Arjun, would you like to see if we could share Judith's video?
Yes, I'll start that now.
Hello everyone, my name is Judith. I'm a Fleming Fund Fellow under the Human Health AMR Advisory Fellowship. I am also a member to the PNG AMR Secretariat. It is a pleasure for me to present in this session. The topic of the presentation is addressing antimicrobial resistance in Papua New Guinea. PNG is a low middle income country. In 2018, the population projected to be 8.6 million. GDP per capita was estimated at $23.5 billion US dollars, 2018. A total of 40% of the population is under 15 years of age, and 4% is over 60 years of age. The adult literacy rate for the population over 15 years is 60%. Like other low middle income countries, Papua New Guinea faces health system challenges, including rapid population growth, limited resources, high maternal mortality ratio, double burden of communicable and non-communicable disease, etc. Overview of AMR. The PNG Medicines Policy 2014 recognizes AMR as a threat and proposes to adopt global measures to mitigate the emergence of resistance on AMR. Dr. Tapang, WHO country representative, also alluded that AMR is a rising issue in PNG at the first PNG AMR forum, and I quote, "We have a silent war on our hands in Papua New Guinea, and that is antimicrobial resistance. Multi-drug resistant to the tuberculosis drugs and HIV pre-treatment drug resistance are rising examples of this." This table shows resistant data provided by a research institute. Isolates were obtained from multiple studies conducted at various points in time between 2004 and 2015. A number of pathogens showed high resistance to sulfamethoxazole and trimethoprim and tetracycline. MRSA was first reported in 1960s and are resistant to all available penicillin and other beta-lactam antibiotics. MRSA is a common cause of bacterial osteomyelitis in PNG. Two other hospitals also reported more than 75% of MRSA, as can be seen in the graph. Another study conducted in 2017 also concluded that MRSA is likely to account for a clinically important proportion of staphylococcal disease in PNG. Now we can see the need to address AMR in PNG. So in 2016, there was a country situation analysis conducted. And the country situation analysis was conducted according to the WHO policy package. And PNG observed that under the 6 elements of the WHO policy package, as seen in this table, the assessment scores represent independent view of the CS situation analysis conducted by WHO in 2016, and it does not represent the situation at the time of writing the National Action Plan. So you can see a minimal activity of AMR. The recommendations for this situation analysis was to address the governance mechanism, surveillance and laboratory capacity, access to and quality of essential medicines, rational use of medicines in humans and animals, infection preventive and control, and research and development. In 2017, there were 5 participants, including myself, who participated in the Pacific Kickstart AMR, which was a very important program that we attended. And when upon our return as a team, we compiled notes and contributed together to develop the National Action Plan. Because while we were there, we got to see how other Pacific islanders were addressing AMR. So that gave us a perspective on how we could do ours. In 2018, unveiling of the AMR NAP, National Action Plan, was unveiled in 2018 by the then Minister of Health and Secretary of Health, WHO representative, and other key stakeholders present at that time. And there was political commitment and multi-sectoral collaboration. In 2019, there were the first Fleming Fund team scoping visit with PNG AMR committee. So after the National Action Plan was developed, we had Fleming Fund coming in. And towards the end, we hosted the first PNG AMR forum with key authorities from human health, animal health, and environmental sectors, with other key stakeholders. The first forum was held, and also the memorandum of understanding between the four sectors was signed at that time to quadripartite arrangement in One Health. This is a key document that is now currently enabling all sectors to work together to address AMR. Beginning of this year, we had PNG fellows meeting with their mentors. Early this year, we are privileged to have eight fellows participating in this Fleming Fund scheme, fellowship scheme. They're all from the three different sectors. We also have the Fleming Fund country grant, started early this year, and will develop. The main objective of this country grant is to develop national surveillance for AMR organisms and strengthen microbiological services in 5 selected hospitals. This is a picture taken last month, 2 fellows with their mentors during a site visit. Besides all that, we continue to participate in the annual Antimicrobial Awareness Week since 2016. And as can be seen in these pictures, we participate in school visits, clinic visits, hospital visits, poster distribution, and we've also participated in the WHO pledge to be a good steward of AMR. Now, an interesting scenario in PNG, amoxicillin is seen as the magic bullet. Unfortunately, amoxicillin is sold everywhere in the streets by the so-called street pharmacists. They sell 1 capsule for 2 cents. There is an increasing need to advocate for that. And we are currently in the process of addressing that. But yeah, people take amoxicillin for headache, flu, body aches, just literally everything. They just take amoxicillin. It's a sad scenario, and we're currently addressing it. To this date, there is no baseline study of the level of knowledge and attitude of antibiotics use and antimicrobial resistance among the citizens, even the health professionals. So as a fellow, I am currently working on this research proposal to collect data to assess the level of knowledge among the community members, pharmacists, and health practitioners. My research is currently with the ethical team, and I hope to conduct the research early next year. And it will be the first of its kind, and we are looking forward for some interesting results. Thank you everyone for listening.
Thanks, Judith, and thanks, Kirsty. Back to you.
Thank you. Judith, what a terrific talk. Thank you so very much. Now, I think we actually might have Judith online. I'm not sure how good the internet connection will be, but are you there, Judith, and can you hear us?
Yes, I can hear you.
There you are. Well done. What a great talk. I'm just watching the chat to see if there's any questions. I can see a thank you and a well done coming through for you. I think Judith's been a great example of a really interesting type of fellow, focusing on this advocacy and awareness raising. And I guess that's really important in Antimicrobial Awareness Week. Judith, do you want to take a minute to talk a little bit about what you've been doing in Antimicrobial Awareness Week, where you are? Are there any activities going on?
Been a good journey for me thus far. Just yesterday we had our second PNG AMR forum. It was a very good attendance. We had this time a full 1L team was present. We had 1L experts from overseas dialing into, and it was a good, very good forum we had. So like I said, it is a new area for us to introduce to PNG, and I am privileged to be part of it since the beginning. And we're looking forward for more awareness and journey next year. Thank you.
Fabulous work, Judith. So I can't see any other specific questions. We had a question earlier on. I think, I'm not sure if this is, maybe Judith can tackle it and I can tackle it too, but the question was around, are we involving nurses in a lot of the activities yet? And what's happened with you, Judith? Are nurses interested in AMR and in, are they getting involved in the activities that are going on?
The drive was from a pharmacist, and from the higher levels, yeah. So slowly we are trying to address it to the physicians, and then most likely to involve the nurses. But at this stage, we do not have the nurses involved yet. Okay.
And I can reflect from the elements in the talk that I gave earlier on. In the Fleming fellowships are not involving nurses yet. They've mostly focused on laboratory staff and pharmacists because they're focused on data collection. But the Combat AMR and the MRFF programs will, through the infection control activity in particular, focus a lot on nurses. So I think gradually the nurses are coming on board, which is great. Is there anything else you'd like to say, Judith, while you have an opportunity with the group here? We might have lost the internet. I'll leave it there, but thank you very much, Judith, for participating. We're really.
I'd like to say thank you to the Fleming Farm Fellows.
I think the internet's a challenge. We've had this happen before. But Judith, I think I heard the start of what you were saying, which was to thank the Fleming Fund
I'd
Fellows.
like to say thank you to all, thank you to the Fleming Great Help, and thank you to
We might be being challenged by that. But it was lovely to hear your voice and to be able to see you, Judith. So thank you very much for taking the time to join us and for delivering that excellent talk. We might move forward to the next speaker now. And we have, I'm really delighted to introduce a contributor from the WHO Western Pacific Regional Office, Dr. Takeshi Nishijima. Takeshi is a technical officer in the Antimicrobial Resistance, Essential Medicines and Health Technologies Unit in the Division of Health Systems at the WHO Regional Office for the Western Pacific. By background, Dr. Nishijima is an infectious diseases physician, and he's also been supporting the COVID-19 response as a focal point on clinical management, infection prevention and control, research and science for the regional office and for the WHO country office in the Western Pacific region. And we've met a number of times, and I'm really Dr. Takeshi is a lovely person to work with, so we're very excited that, that he's been able to join us today, and he's going to talk to us a little bit about the WHO antimicrobial resistance and stewardship programs in the Western Pacific region. So I'll hand over now to Takeshi.
Yeah, thank you so much, Dr. Buising, for such a kind introduction. Can you hear me okay?
Yes, we can. We can see you and hear you.
Okay. Okay, thank you so much. So I will try to share my screen from my end. Can you see my screen as like a slide presentation mode?
Yes, we can.
Okay, great. All right. Okay. So again, thank you very much for this opportunity to to present here. Thank you so much. I am very honored, and I wish the very successful the World Antimicrobial Awareness Week for Australia and then colleagues who are joining here. So yeah, thank you so much for Kirsty for kind of introduction. Yes, I'm going to talk a little bit about the activities where WIPLO, the WHO Regional Office for the Western Pacific, has been leading. And then my talk will be very much focusing on the framework document we have developed and which has been endorsed by the member states last year, 2019, in October, during the regional committee meeting. My apology that my background for my video is, this is from the Philippines. When I made a presentation for the Philippine government yesterday, they asked me to use this background, and then my apology, I didn't know how to fix it to the normal background. So please bear with me. So let me start. Okay. So we have a regional director called Dr. Takeshi Kasai. And then when he started his work, we have developed the policy paper called For the Future Towards the Healthiest and the Safest Region. This is a vision for us to work with the member states and the partners in the Western Pacific. And then we have four main pillars or areas we would like to very much focus on. One is a health security, including antimicrobial resistance. Two, climate change, environment, and health. Three, non-communicable diseases and aging. Four, reaching the unreached. It's a little bit difficult to understand, but this is about the all traditional communicable diseases, where people and the communities are still afflicted by infectious diseases, and then high rates of maternal and infant mortality. So following this vision paper, we have developed the framework for accelerating action to fight antimicrobial resistance in the Western Pacific region. And then this is in effect. So the objective of this framework is to accelerate the implementation of the 2014 Regional Action Agenda and National Action Plan on AMR through a set of operational shifts and new ways of working. Number two, to catalyze the opportunities provided by global and regional movement to support member states to accelerate action to fight AMR. Number three, to strengthen existing regional mechanisms. So this is a summary of the framework and then showing the operational shifts, which is elucidated in the vision paper to combat AMR in our region. This is a little bit complicated, but let me explain a little bit. So, as a characteristic of the AMR, it's not only causing problem right now, but will continue in the future, meaning that our strategy needs to be future-oriented. And then here we talk about agility including high-level political dialogue, political agility, and such and such. For this, we will promote policy dialogue between multi-stakeholders, and then political agility by updating the AMR disease burden in our region, and then also updating global movement. This operational shift number 1, we call it backcasting. Second characteristics of the AMR is that it will affect not only a small portion of us, but for everyone, every one of us. So this is a reason to have the movement to avert the impact of AMR. And why this is so important. For this, we need to have a shared value and a shared culture. We will promote campaign, stewardship, and then also corporate social responsibilities for the private companies. We call this operational shift number 2 as championing health beyond the health sector. The third characteristics of the AMR is infinite. Well, this AMR will continue infinitely, so we need to have a sustainable system or mechanism to fight against AMR. To make our fight against AMR sustainable, we need to use existing mechanism to have our fight against AMR efficient. UPSED 3, which is an Asia-Pacific strategy for emerging diseases and public health emergencies. This is a scheme in Asia-Pacific to strengthen preparedness for the emerging diseases, which has been proved very useful in the fight against COVID-19. And then also we talk about regulation and the public health programs, which is already in place in our member states, to use them in the fight against AMR. This third operational shift is called system approach for sustainability. Fourth characteristic of the AMR is this is contextual, meaning the AMR is different in each member state and maybe in each subnational level as well, which is of course depends on the capacity of each country. So strategy needs to be grounded. So understanding what is going on in the country or this area or this subnational area is very, very important. So this is the reason we think surveillance, including monitoring of antimicrobial consumption and idea of One Health across intersectional collaboration is very important. This operational shift number 4, we call building solutions from ground up, or we call it ground up, which might not sound a little bit weird for the native English speakers. But this is the summary of our framework document. And then our key priority for the 2020 and the 2021 is strengthen system to combat AMR for sustainability. And then we've been working on to develop a regional guidance on surveillance system, as well as outbreak response with Doherty team as a contracted partner. And then we thank very much for their support in this guidance development. Antimicrobial consumption monitoring, I will talk a little bit later on this Western Pacific regional antimicrobial surveillance system, and then also stewardship, of course. And then I will talk a little bit about AMR movement later as well. So this year's World Antimicrobial Awareness Week, we have a slogan, Stewards for the Future, one region, one movement to fight antimicrobial resistance. These are the posters we developed for this year's campaign. But what I would like to stress here is that we would not like to call it as a campaign, but rather as a movement. Since if we are making actions only during the WOW or World Antimicrobial Awareness Week, it is not enough to fight AMR. This is a reason why our slogan has movement, the world as a movement. We need sustained action and behavior change from every one of us in our everyday life, which will eventually avert the impact of AMR. We are encouraging people to make pledge at our website here, to make a pledge to be a steward, to fight against AMR by making small actions in your everyday life. So you are very much welcome to make a pledge on this website and then also become a steward. Let me introduce a little bit about GeoWePlex. This is a regional system for antimicrobial consumption. And then I am very pleased to announce that already 13 countries and areas in our region, including Australia, showed their interest for this regional system. And then we have been finalizing the report for the first year of rollout, which has the data from 7 member states in details. And we are finalizing the report very, very soon. And I will show a little bit of that data later in this presentation. So WePlex aims to conduct AMC or antimicrobial consumption across the Western Pacific region with the aim to increase multi-stakeholder accountability and then strengthening stewardship, of course, and then to improve health outcome. It will aim to set up and build capacity for AMC monitoring system in country and ensure the information on antimicrobial consumption and use will influence national policies and strengthen stewardship and improve clinical management. So we have established a web-based regional database to capture the data. And then what I would like to stress is we have a 3 level of the data collection. 1 at the national level, 2 at the hospital level, and then 3 at the community level. The system for the community level and also hospital level is still under the development, but we are very happy to see the progress we are making with the support from the member states. So let me show a little bit of the data from the first rollout of WePlex. This is a national level data in 2018. And then 7 member states here have provided the detailed data. So we thank them very much. But please note, this is still preliminary data. They are being validated and then only intended to show the purpose of this presentation. So please do not cite this data. So this is the data for 7 member states showing the DID, which is defined daily dose per 1,000 inhabitants per day. And then we can see the variety of DID among those 7 member states. This shows the national level categorization of AWARE categorization, which is promoted by WHO. As we know, green shows the access category, and then orange shows the watch category, and then red, here we see a very, very small portion here, but the red shows reserve category antimicrobials. And then WHO is or has been encouraging the member states to have access, the amount of access antimicrobials beyond 60%, 60%. So it looks like most member states here have cleared that threshold by having more than 60% of the amount of using access antimicrobials in 2018. But please again note, there's a limitation in the interpretation of this data, because this is basically the total or sum of all imported antimicrobials plus antimicrobials which is locally produced. So we don't know how these medications, antimicrobials are used to treat which disease. We don't have that information. And this is still rough data by definition. So what is our strategic planning for the future by 2023? We have 3 focus areas. 1, to strengthen systems as a foundation for sustainable action, or AMR, including antimicrobial consumption monitoring, AMR surveillance, and also, of course, a stewardship. Focus area number 2, championing health beyond the health sector through the AMR movement. Here, I would like to stress again the word or terminology movement. Yeah, we shall not limit our advocacy event or activity during this while, but it should continue throughout. This is about the behavior change for every one of us, which can continue in the future to avert the impact of AMR. Number 3, multisectoral collaboration on AMR, including the establishment of Western Pacific Region AMR Consortium. We are thinking about establishing this consortium as a kind of the scheme for the think tank, which will have a role of making innovative research or facilitating the innovative research, and then share such research data or results of products among the Western Pacific region or across the globe to improve or facilitate or help fight against AMR. So this is the last slide. Thank you so much for using this opportunity. I would like to announce the virtual rally where we are planning to have to celebrate a steward who have made pledges to fight against AMR for the future on 27th of November. This is a Melbourne time, but it's from 1 p.m. to 2 p.m. Melbourne time with a Zoom link, this one. And then thank you, Dr. Buising again. It will be moderated by Dr. Kirsty Buising. Thank you very much. And I wish very fruitful WOW, or World Antimicrobial Awareness Week in Australia, and all of you. And thank you so much for this opportunity to present here. Thank you.
Thank you, Takeshi. What a terrific talk. And you've already got, Takeshi, some comments that have come through. So one here that's from Fiona Gotterson, who's one of the PhD fellows here and an AMS champion, and she's sent her congratulations, particularly looking at the framework. And I must say I was very impressed by it too. Fiona's comment says it's really terrific to see shared values and culture reflected in the principles and to see it explicitly stated. And it's lovely to see recognition of context being important. So, you know, well done to everybody who's worked on that. And I thought the same thing. I thought a lot of thought has gone into that. So I think it will be very useful for many of us in sitting back and thinking about our activities. Are there any other questions for Takeshi while we have him here? I appreciate this must be a very busy week for you, Takeshi, with Antimicrobial Awareness Week, so thank you for making time. Is there anything you'd like to say? I guess we want to encourage people to make the pledge, to sign the pledge. This would be a good time to remind everyone online. But is there anything else you'd like to say to the group while you have their attention Takeshi.
Yeah, thank you very much, Kirsty, and then also Fiona for the kind comment. We very much appreciate the, you know, first and foremost, again, thank you so much for, you know, this opportunity to present on behalf of WIPLO, and then again for the framework we are having for this region to fight AMR. And then, you know, I would like to encourage all of us to promote this idea of movement and then pledge. So thank you so much, Kirsty, for, you know, saying that again in your remark. And then thank you so much for this kind of collaboration and then strengthening the network between you and then any one of us joining this webinar or, you know, training for the WOW. So thank you very much.
Thank you, Takeshi. So we might move on to our next speaker, and I can see she's already arrived, which is wonderful. Welcome, Joanna. So we're delighted to invite Dr. Joanna McKenzie to speak with us. Now, Joanna is a specialist in One Health epidemiology and international development in the MEPI lab at the School of Veterinary Science, Massey University, New Zealand. She's currently a global One Health consultant to the Fleming Fund's AMR program in Africa and Asia. In addition, she's the One Health specialist for the Combat AMR program in the South Pacific that's funded by DFAT. She's been responsible for developing and delivering interdisciplinary One Health education, research and zoonotic disease control policy programs, and is interested in extensive expertise and has extensive expertise and experience in implementing AMR and infectious diseases surveillance, particularly in resource limited settings. And Joanna's going to speak with us this afternoon around One Health perspectives on regional AMR programs. So welcome, Joanna, and I'll pass the floor to you.
Thank you. Sorry, I just managed to get away from the sharing screen. What's happened to me? Okay, sorry about that. Share screen. Okay, thanks Kirsty, and thanks very much to the organisers for the invitation to share some perspectives on One Health regional AMR capacity building programs. I'll just skip through these first two slides quite quickly because they were really covered in my background. Yeah, just to say that I'm involved with the Fleming Fund program funded by the UK Department of Health and Social Care, strengthening AMR and AMU surveillance in 24 countries in Asia and Africa, and also in the Combat AMR program in 4 countries in the Pacific, which is led by Doherty and funded by DFAT. The focus on the Fleming Fund program is building capacity to implement AMR and AMU surveillance, while the focus of the Combat AMR program is a bit broader, including a situation analysis of AMR and AMU, and strengthening AMU stewardship, infection prevention and control, and AMR surveillance in humans and animals in the 4 countries in the Pacific. I'm also involved with, I've also been involved with Massey's regional One Health capacity building programs involving doctors and veterinarians from South Asia, Mongolia and China. And these programs involved a combination of a formal education with master's degrees combined with collaborative applied field research program. So what's the value of a One Health approach to address AMR? As you can see from the diagram, AMR is an extremely complex, multifactorial health issue that involves humans, animals, aquatic species, plants, food, and the environment. And addressing AMR is beyond the understandings and capacities and the mandates of a single sector and requires a multi-sectoral One Health approach. So there are a number of levels at which a One Health approach to AMR is being implemented. At the global level, with the tripartite of WHO, FAO and OIE, who are collaborating to address AMR across the multiple sectors. WHO has produced a range of guidelines, including a template for countries' national AMR action plans, the global AMR surveillance system, and other guidelines relating to AMS and infection prevention and control. And they also have the advisory group for integrated surveillance for AMR resistance. FAO is producing a set of guidelines to support AMR surveillance in animals and aquatic species, and OIE has a system for member countries to report data on nationally aggregated AMU in animals. At the regional scale, examples include the European Food Safety Authority, ECDC AMR surveillance program in humans and animals. And as we've just heard from the previous speaker, WHO has a number of regional programs and likewise FAO. At the national level, One Health collaboration occurs in the National AMR Coordinating Committee, which is responsible for strategic oversight of AMR control, and in particular implementation of the National Action Plan for AMR. In some cases, this committee comprises representatives from the Ministries of Health, Agriculture and Environment, plus the UN agencies, while in other cases it's more of a broader AMR platform that's made up of representatives from the government, from universities, UN organisations, NGOs and community organisations. There's also multi-sectoral technical leadership at the national level in the form of a multi-sectoral technical committee or working group, which provides leadership in designing programs for AMR surveillance, antimicrobial stewardship and other areas, and also for sharing and interpreting results from the different sectors. And at the local level, there are more informal collaborations involving local professionals from the different sectors working together to address AMR. So I thought it'd be useful to look at what is likely to underpin a successful collaboration to address AMR. So firstly, to maintain a successful One Health collaboration to address AMR, it's important that those involved recognise the value of the One Health approach, which is to effectively address AMR involves understanding the factors that drive AMR within each sector and those that contribute to AMR in other sectors, so that the important factors across all sectors can be addressed. Secondly, that collaborators see AMR as a shared health issue that impacts the health of animals, aquatic species and plants, as well as that of humans. And recognising it's an important issue to maintain food security and also to protect animal welfare, as well as certainly protecting human health. Thirdly, that collaborators understand AMR in their own sectors and in the other sectors. What are the important resistance patterns in each sector? How are the antimicrobials used and for what reason? Who has access to drugs? What are the critically important antimicrobials for each sector? So this is really reflecting an attitude of understanding one's own sector, but also understanding AMR in the other sectors. It's important that the collaborators generate evidence of transmission of AMR between populations, within and between populations, and understand the contribution of environmental and foodborne pathways. So for example, ESBL, E. coli have been thought to be a major, in animals, thought to be a major source of resistance for people. But as more research is done, this seems to be a less likely pathway, or there's less evidence for this pathway than previously thought. Whereas non-typhoidal salmonella, there seems to be actually reasonably strong evidence for transmission of resistant bacteria and or resistant salmonella and from animals to humans. And finally, it's an important outcome is that the collaboration results in development of appropriate policies and programs to mitigate AMR. That's policies that target the important risk factors that have multi-sectoral and multidisciplinary inputs, so they're implemented in a way that's effective. For example, changing clinician or veterinarian or farmer use of antibiotics involves understanding the access and pricing of antibiotics, the role of the pharmaceutical industry, improved skills to diagnose and treat disease, utilising lab resources to guide treatment, understanding alternative approaches to manage disease rather than treat with antibiotics such as vaccines and on-farm biosecurity. So really addressing the range of factors in policy. It's also important that appropriate legislation is developed and it's implemented in a way that achieves the desired outcome. So for example, banning mixing of antibiotics in feed with animal feed and feed mills is not a particularly effective way of controlling the use of antimicrobials as growth promotants, as it can result in even worse outcomes than using growth promotants mixed at the feed mill. For example, it might result in farmers mixing antibiotics with feed on their own farm, and they may not mix it evenly, which might result in uneven mix through the feed. So some animals getting an overdose, some animals getting an underdose, which can in turn, exacerbate the emergence of resistance. It's also useful to look at a few examples of what One Health isn't. So let's look at some perceptions that aren't an accurate reflection of a One Health approach to address AMR. So I've noticed some terminology that's sort of crept into the Fleming Fund program. That is, we're working with human health plus One Health sectors. This really implies that One Health is the responsibility of the sectors other than human health. And if you flip this around from the animal health perspective, then One Health is animal health plus the One Health sectors, which includes human health, environment, and the agriculture and agriculture. So there are really no such things as One Health sectors. An important misconception, I guess, that has a significant impact on a successful One Health collaboration is the perception that the AMR problems in humans is caused by the high volumes of antimicrobials used in animals. It's not an uncommon perception amongst those, particularly in the human health sector, and it is, and some in the animal health sector are actually beginning to believe this particular narrative. This can lead to members of the human health sector blaming animal production for the AMR problem. Firstly, it's not true that use of antimicrobials in animals is the major contributor to AMR in humans. While animals certainly do contribute to AMR in humans, it's factors associated with humans that contribute to the majority of AMR in humans. If you just take a look at the diagram below, the two photos below, you can see that there are issues both on the human health and animal health in terms of public access and sort of leading to excessive use of antimicrobials. And secondly, effective collaborations are built on trust, respect and understanding. Blaming members of the animal health sector for the blaming members of the animal health sector for the AMR problem in humans does not create a constructive collaborative relationship to address AMR in people, animals, plants and the environment. Another perception is that some people believe that by putting data from all the sectors into a common database or a data warehouse and having it analysed by a statistician will somehow magically generate an understanding of transmission-resistant bacteria across sectors. I believe that it's important that people generating the data are responsible for analysing and interpreting their own data as they understand the biases in the data and the inferences that can be generated. So I think it's useful, initially in particular, useful to keep the data separate, that each sector is responsible for managing and storing its own data, and that they come together to discuss the results of their AMR surveillance. And over time, once there's an understanding of the nature of the data that and the format that best facilitates analyses, then joint databases can be developed, such as that used in the Canadian Integrated Program for AMR Resistance. Another perception is that people make the comment, oh, look, we're running training programs involving people from all the different sectors. We're doing One Health. Well, training is certainly important for One Health to build relationships and cross-sectoral understanding. However, it's only a part of the One Health approach. So let's look at a few of the challenges in actually facilitating, generating a One Health approach to AMR. Moving from words to reality is challenging. And many people know it's important to have a One Health approach, and they use the words, we're using a One Health approach, but without necessarily changing their behaviours or changing their way of thinking. One Health does require doing things differently and understanding the wider picture of AMR within one's own sector and in the other sectors, and understanding the links between the sectors. Collaborations are context specific and they come in different forms, and one size doesn't fit all. They're strongly influenced by the political and cultural environment in a country, and some cultures are naturally more collaborative than others. And it's often easier in smaller countries where people from the different sectors know each other. While some political environments don't support collaboration and information sharing, and it's really a struggle to get a collaborative program going in these countries. Collaborations are also affected by power hierarchies, which may impact on the level of trust and sharing of information. So a few more challenges, and an important challenge is that the different capacity that's in the human and the animal health sectors for AMR diagnosis and for undertaking surveillance, and also for AMR and AMU surveillance. And this has and in the same vein, there are different levels of funding and resources which impact the capacity and the amount of information that a sector can contribute to collaboration. And we found in the Fleming Fund program that in a number of countries, the animal health sector doesn't have the data yet on AMR and particularly in zoonotic bacteria, which they can bring to a discussion with their human health colleagues. So this limits their ability to contribute, it limits their confidence in contributing. But once they have data, then they've got something to bring to the table and to share and to build the relationship with their colleagues. A number of One Health platforms have been established through the Global Health Security and other programs to address endemic and emerging zoonotic diseases. And some countries have successfully incorporated AMR into the activities of these platforms and building on the existing relationships in the platforms. In other countries, this hasn't been achievable. And one of the reasons being that the members of the existing One Health platform for zoonotic diseases are different to those for AMR, particularly in the Ministry of Health, where the responsibility for AMR is usually with the Clinical Services Directorate, while the responsibility for zoonotic diseases is with the Public Health Directorate. So how can we support a One Health approach? So important aspects are building capacity to address what I just referred to before, especially in the animal health and the environment sectors, so that they have data and confidence to share information and discuss results with their human health colleagues. To build partnerships, and I emphasize partnerships are here, whereby members of the collaborations come together as equals rather than as subordinates, and to build relationships. And relationships are built through working together on joint programs, understanding each other's operating environment and each other's perspective. The fellowship scheme and the Fleming Fund program is designed to build One Health relationships by building awareness of the value of the One Health approach, building relationships and understanding of each other's sectors, and where resistance in one sector may contribute to that in another. There's a need to support both formal and informal collaborations, supporting the establishment of formal organisational structures with members from multiple sectors with terms of references that outline responsibility of the different members provides an important framework. However, it's also important to facilitate relationships and understanding about AMR to achieve an effective collaboration within the organisational framework. Likewise, supporting a multi-sectoral technical working group with members from the different sectors with terms of references helps to provide the framework to support collaboration amongst the technical people from different sectors. But again, providing expertise where necessary to support the technical working group understand AMR and provide support and encouragement for meetings is important to achieve an effective collaboration. And a final point, it's also important that organisations that are managing One Health AMR capacity building programs also model a One Health approach themselves, with representation of people from different sectors and facilitating collaboration between members of the different sectors. So my major involvement in AMR has been supporting the Fleming Fund program to strengthen a One Health approach to AMR and AMU surveillance. An important question at the beginning of the program was, what does a One Health AMR surveillance system look like? And this raises some interesting issues regarding implementing a One Health approach. How do we achieve a One Health approach that supports collaboration between the sectors, but still supports the roles of individuals within their organisation? Because each sector has responsibilities for their sectoral mandate, plus responsibilities to identify and manage risks to other sectors. So I feel it's important to design surveillance in a way that builds a partnership between people in the different sectors, so they come together as colleagues with their information that they produce themselves and not as subordinates. And in the beginning of the program, there was a risk of the animal health and the other sectors coming under the wing of human health or the Ministry of Health to achieve a One Health approach that focused on identifying risks to AMR in humans. However, to strengthen the partnership approach, we felt it was important to strengthen capacity within each sector and to support the One Health approach by the animal health sector focusing on identifying zoonotic AMR risks carried by healthy animals by investigating resistance and a common set of bacteria and antimicrobial combinations in both animal health and human health. And in addition, creating the opportunity for them to collaborate and share results from their surveillance in a multi-sectoral technical working group. An important step at the beginning of the program was to get everyone thinking of AMR surveillance not just as being the responsibility of the laboratories, which was an overriding perception at the beginning, but as a system of which laboratories are a part, as illustrated in this slide. So the surveillance system involves all components of surveillance, from sample collection and diagnostic testing and, Oh, all right, I've lost my transitions here. Okay, so from starting at the bottom, from sample collection, diagnostic testing and quality assurance, data analysis, and sharing the data within the technical working group, then sharing results amongst the sectors, interpreting the collective results, and using these to recommend policies and programs to address AMR at the AMR coordinating level. And the value of this system, it both strengthens each sector to implement surveillance and to share results and to use surveillance results for decision making. As other sectors become involved, like the environment and the food sector, then the surveillance system can expand accordingly. So in the Fleming Fund program, in keeping with our approach of strengthening the individual sectors, surveillance within the human and the animal health sectors, and also strengthening a One Health approach to AMR and AMU surveillance, the program was based around three major objectives: strengthening One Health AMR and AMU surveillance, strengthening AMR and AMU surveillance in humans, and likewise in animals. The specific outputs of the One Health surveillance objective, we tailor to the organisational structures in the countries and the sorts of where they're at with their collaboration and what they needed to support the One Health approach. So the top left, or the top example reflects a country that had a multi-sectoral coordinating committee for AMR already in place, and the project outputs included the multi-sectoral technical working group sharing surveillance and research outcomes with the Multi-Sectoral Coordinating Committee. The committee integrating these into knowledge on AMR, sharing this and sharing information nationally and globally. Whereas the second example down the bottom is a country where the political environment didn't support a multi-sectoral AMR committee. And so to strengthen a One Health approach to AMR surveillance, we focused on strengthening more informal sharing through organising national symposia and through technical experts coming together to share information. Finally, strengthening a One Health approach to AMR is challenging, and it requires time and resources to build capacity within all sectors, and especially in the more under-resourced sectors such as the animal health and environment sector, to support activities that build relationships amongst people from the different sectors, to generate understanding of the operating environment and the AMR situation within each other's sectors. And just a funny example, I guess, from our previous AMR, not our AMR, our previous One Health programs. One country, so the program involved a group of doctors and vets, and one of their assignments addressed something about the gastrointestinal tract. And the doctors, one of the doctors in the group turned around to the vets and said, you know, the gastrointestinal system starts at the mouth and ends at the anus. And the vets kind of looked at him as if to say, oh. So it's really important that, you know, there's an understanding of each other's knowledge, and that it's that they're often, you know, applying the same approaches to their operating environment and the disease-related situation. Also, to generate evidence of transmission of resistance bacteria or resistance genes between sectors, to identify priority AMR risks to be mitigated in each sector, and finally to develop appropriate policies and programs within the different sectors. Thank you.
Thank you, Joanna, for a very comprehensive talk. Thank you very much. And I've spotted we're running slightly short on time, but there has been one question, so I'll offer it up, Joanna, and see if you can think about a brief answer. So the question is around whether this, and I gather the questioner perhaps means the Fleming Fund activity is the first time that One Health collaboration is being fostered with official support from local governments and from an external sponsor. To your knowledge, is that the case?
I don't think the Fleming Fund initiated the multi-sectoral approach. I mean, I think really the tripartite, you know, and WHO through the developing the national action plans really fostered, or they really they really provided an impetus for a One Health approach by guiding the different sectors to, or the countries to engage the different sectors and activities in those sectors in the National Action Plan. And then the Fleming Fund aim was to support countries implement the surveillance component of their National Action Plan and to really facilitate a One Health approach.
Great, thank you very much. So we might move on in the interest of time. We'll move on to the next speaker, but we're very grateful for your contribution, Joanna. That was terrific. Our next speaker, I'm once again excited to be able to introduce to you one of the fellows from the Fleming Fellowship Program that the Doherty Institute is helping to host. And we have Takeshi Gompo. And Takeshi is the Animal Health AMR Surveillance Fellow from Nepal. So Takeshi is a veterinarian with specialist training in epidemiology. He's currently working as a lead for the bacteriology unit at the Central Veterinary Laboratory in Kathmandu, Nepal. He's the Fleming Fund AMR Surveillance Fellow for Animal Health in Nepal, and is taking care of AMR and routine work on bacteriology at the National Veterinary Laboratory. Now we have Takeshi's talk pre-recorded, so we can play the video for you, but I understand he's here, and if our internet is good enough, we may be able to involve him in some questions at the other end. But I'll welcome Arjun to perhaps help us to play the video from Takeshi.
Thanks, Kirsty.
Hello, good morning, good afternoon, namaste. From Nepal, I am Tulsiram Gompo, veterinary officer, currently working at Central Veterinary Laboratory at Bacteriology Unit. Today, I'm going to talk about passive AMR surveillance in poultry specimen of year 2019 to 2020. This is Central Veterinary Laboratory, and it is the National Reference Lab for Animal Diseases, and it is also the National Reference Lab for AMR in animal health. Before going to talk about the data, I want to show you how the sample flowed to the veterinary laboratory. First, the farmers submit dead birds, and they were taken to the necropsy room, and vet performs necropsy, and they collect samples and submit to the lab, mostly liver. At the lab, the process of culture and identification will take place, and they also do antibiotic sensitivity test, and finally they go for reporting. Today I am going to talk about the passive surveillance data of year 2019 and 2020 with some descriptive study. I want to show you the 5-year summary of the data of 2015 to 2020. If you glance over the pictures, E. coli is the predominant species, followed by Staphylococcus, Salmonella, Klebsiella, Streptococcus, Enterobacter, and so on. On average, there are around 800 total isolates every year, and there would be around 1,000 total sample submission in our lab. But if you look at the year 2019 to 2020, the total isolates is low and total sample submission is also low. It is due to the COVID lockdown, because our lab also remained closed for a few months, and the farmers were not able to submit more samples because of the movement restriction. Now, of year 2019 and 20, if you see the top bacterial isolates, E. coli is the one of the predominant one with 284 isolate, Staphylococcus 74, Klebsiella 36. So that adds up to 657, and total isolate is 512. The important thing is the resistance pattern, and the resistance of common bacterial isolates of tissue samples are described below. Let's start with E. coli. E. coli is resistance against aminoglycosides groups as well. Out of 196 sample tested, we found 50% were resistant to gentamicin. And for the amikacin, out of 84 sample tested, 20% were resistant. And we tried to show this in colorful with red with resistance, and sensitive with this green, and the intermediate with yellow is analogous to traffic signal signs. That means that red means to stop or it's a danger. So now if you look about E. coli resistance against quinolone group, then the condition is quite miserable, because around 71% of the enrofloxacin were resistance against E. coli, and ciprofloxacin also resistance against E. coli with 65%. And if we see the tetracycline, out of 142 sample tested, around 80% were resistant to E. coli. And if we look over the amoxicillin, around 77 were resistance against E. coli for the amoxicillin. And there might be some slight difference between the number because we have used sometime where we switching the antibiotics during the samples, so that produced the different number of samples in the lab. And if we look about the E. coli resistance against cephalosporin and carbapenems, ceftriaxone is around 84% sensitive, and imipenem is around 97% sensitive. This higher sensitivity in ceftriaxone is that it is not found in oral form, so there is less likely of being misused by farmer, and it is only found in injection form, and it is not so widely used. Well, imipenem is only used in human, and it is not prescribed for animal use. So still, these two drugs are quite working better. Now, if we go our Staphylococcus species and compare with gentamicin and tetracycline, Staphylococcus species are resistant with gentamicin as well. 61% of the drugs were resistant to gentamicin. Gentamicin were resistant to Staphylococcus, and 81% were resistant against Staphylococcus for the tetracycline. For the Salmonella, also 72% were sensitive for Salmonella for the gentamicin, but if you look about the ciprofloxacin, they are also 72% were sensitive for Salmonella. Now, if you compare with the ciprofloxacin and gentamicin against Klebsiella, 65% were resistance for the ciprofloxacin, and 72% were resistance to gentamicin for the Klebsiella. In short, there is economic loss among the farmers due to death of poultry birds due to various diseases, and the antibiotic resistance has been a problem in poultry population in Nepal due to injudicious use of antibiotics. And there is also a concern over AMR in poultry that may be associated with the AMR in people. And what we suggest is that the judiciously antimicrobials must be used in animal production. I want to acknowledge all and thank you. And I'm happy to take question if there is. Thank you.
Thank you, Tulsi. That was a terrific presentation, really very clear and easy to follow. Thank you. Now, Tulsi, I can spot, has joined us online. Can we hear you, Tulsi?
Yeah, I can hear.
Excellent. So I'll invite the audience, if there's any questions you'd like to ask Tulsi about his work, please feel free. Tulsi, I guess one of the obvious questions you mentioned about the drugs that aren't used in poultry very much, but what are the more common? Do you know what the more common antimicrobials are that are being used in those poultry populations at the moment?
Well, thank you for the question. In a poultry population, most of the drugs were used in oral form, and that belong to a group of like tetracycline groups, and there are also groups from the quinolones groups like interfloxacin and ciprofloxacin, and there is also the aminos glycoside groups like gentamicin, and in amikacin also being used in injectable form. And still, as the resistance has increased, the people realized that it doesn't work well, so they started giving parenterally, like they are giving by injection. So ceftriaxone, the cephalosporin group, has been also been started. So it's a sign of, like, if we start talking about the resistance and sensitivity, like if we give more knowledge about sensitivity, like veterinarians know that this drug is more sensitive, so they are more likely to switching to that drugs, and I don't know, in long term that may also become resistance. So there should be quite a balance between the using the drugs in poultry population.
That's correct. Well done. Thank you. And there's one other question that's appeared about where do farmers receive education on which antimicrobials to use? Where are most people getting their information?
Well, there is not such an official channel to educate the farmers, but it's a duty of practicing veterinarians, because, for example, when we are also practicing in the in the outpatient department and interacting with farmers, the first thing is we need to educate the farmers by ourselves. It's a duty of veterinarians, paramedics, and even the policy level people who can share a message to the farmers, especially farmers, because unlike in human, the farmers can get the medicine over the counter, and they can medicate their birds, or they can medicate the animal by themselves. What is practice here? So, so there is not so official channel, but need to initiate from every people, like veterinarians and drug distributors, and all the policy people.
Thank you, Tulsi. That's been a terrific discussion. I think in the interest of time, I might have to call the questions to a close, but it's been really terrific to see the outcome of your work. Well done. I might move on to the next presenter, if I may, this will be our final presenter for the day. So I'm really excited to invite Mr. Tabuka Tuatu, representing the Pacific Community, or SPC. So Mr. Tabuka Tuatu is a microbiology scientist and laboratory coordinator for SPC. Tabuka is involved in SPC's Pacific microbiology and AMR program, including contributing to AMR training across the region, working with WHO, PPTC, Fiji National University and DFAT. And the talk being delivered today is about AMR capacity building in Pacific Island countries. And I might hand the forum over to Tabuka. Are you able to hear us and see if we can switch your video on, Tabuka?
Okay, yeah, thank you, Kirsty. Yeah, thank you and good afternoon all. So I'll be presenting today on behalf of Dr. Ecker and the whole of the SPC lab team from Public Health Division SPC in Suva. So I'll be sharing my screen shortly, and I hope you can see it from your end. Is it coming?
Yes, we can see it. You might, yes, there you go. You're going into slide, screen view now. Good on you.
Okay, thanks. Yeah. So during the course of this presentation, I'll be talking firstly on a brief background information on how SPC is involved in this microbiology, AMR and IPC capacity program. Secondly, I'll be talking again, but briefly, on the drivers of AMR in Pacific Island countries and territories, followed by the work that we have conducted so far in a few Pacific Island countries regarding AMR strengthening. And then I'll be finishing off with some of the challenges that we currently face during the delivery of this capacity training program. So following the increase in emergence of antimicrobial resistance and the impact it has on low income and middle income countries, coupled with lack of surveillance infrastructure and regulations to monitor AMR, SPC Public Health team managed to secure funding support through AFD and EU to assist Pacific Island countries in strengthening their microbiology diagnostic capacity to strengthen their microbiologic diagnostic capacity to monitor quality sensitivity testing and to produce accurate and meaningful antibiogram data.
Tabuka, we're noticing your slides aren't advancing, I think. Do you want to try the slideshow again and just check? It looks like it's stuck on the first slide.
Oh, but it's moving on my other screen. Is it not moving from your end, Kirsty?
No, it's not. Just it looks like it's not quite in the what do you call it? The
presentation mode,
yeah.
slideshow mode. Yeah.
Slideshow from beginning. Yeah, I'm on the slideshow now.
It just looks like it's staying in the other view.
It's on the same view. Tabuka, if you close that and share again, just
So
on
stop sharing.
Yep. And if you share again on the one screen, instead of splitting it across two screens, if you could share just on the one screen and try that.
Oh, so I need to turn one screen off.
That might help.
Mm-hmm.
Or you can swap display as well. You can choose to.
And probably, Kirsty, if you have a copy, can you view it from there? No.
I can share the slides on your behalf, Booker.
Yeah, thanks. Probably it's easier. Okay.
Which slide would you like? We can see it presented.
Yep.
Which one would you like to?
Probably from the outline. I'll start from the outline. It will be okay. Okay, so as mentioned earlier, during the course of this presentation, I'll be talking firstly on a brief background information on how SBC is involved in this microbiology, AMR and IPC capacity strengthening program. Secondly, I'll be talking but briefly on the drivers of AMR in Pacific Island countries and territories, followed by SBC strengthening activities, or outlining some of the work that we have conducted so far in a few Pacific Island countries. And then I'll be finishing off with some of the challenges that we have encountered during the delivery of these AMR capacity training. So next slide, please. Okay, so background, with the increase in the emergence of antimicrobial resistance and the impact it has on low-income and middle-income countries, coupled with lack of surveillance infrastructure and regulations to monitor for AMR, SBC Public Health team managed to secure funding support through AFD and EU to assist Pacific Island countries in strengthening their microbiology diagnostic capacity to monitor quality sensitivity testing and to produce accurate and meaningful antibiogram data. Next slide, please. The drivers of AMR, as we all know, are listed in this slide. And this is where SBC and its regional partners are focusing their approach in providing technical assistance to Pacific Island countries to help them address the major AMR issues that they are currently faced with. Next, please. So during the development of this strengthening capacity training on microbiology and AMR, in 2018, that's the first time that we managed to discuss this issue and managed to establish a technical working group, which comprises of Fiji National University, Pacific Island Health Officers Association, PIOA, the Pacific Pathology Training Center, PPTC in Wellington, SBC, and WHO. So we managed to get a few representatives from these organizations, and we managed to meet on a daily basis during 2018 and try to to come up and develop a standardized training curriculum which encompasses both the theory and the practical components to address the key components such as microbiology diagnostic methods, antibiotic stewardship, infection prevention and control, and surveillance and control of AMR. During the planning of this technical working group, it was quite difficult at times because considering the busy schedules of other partners. So at times it was a challenge for us to try and coordinate this meeting with these partners. But eventually, towards the end of 2018, we managed to establish a draft standardized training curriculum. So the training curriculum was basically, the training was involved, was to be run for 2 weeks. The first week was basically basic microbiology, introduction to bacteriology, virology, and this was targeted to laboratory personnel to strengthen their diagnostic methods, and more importantly, to address the quality assurance that is really important in order for them to produce accurate and reliable antibiograms. The second week was more clinical microbiology, and it also covers some IPC and antibiotic stewardship. During the course of the 2 weeks training, the morning session was only presentations with 2 to 3 topics or issues that were presented. And then in the afternoon, it was mainly practical sessions for laboratory scientists. So the participants that were targeted during this 2 weeks training were basically laboratory personnel, pharmacists, IPC nurses, clinicians, pathologists, and nurses. So these were the targeted participants for this training. Next slide, please. So in beginning of middle of 2019, we managed to roll out the training in Kiribati, Samoa, Cook Islands, and Nauru. So we completed 4 Pacific Island countries running the training curriculum, the microbiology training curriculum for these 4 countries. In 2020, we were faced with the lockdown of COVID-19 pandemic, but we managed to do Fiji, Central Division, Northern Division, Lambasa, and Western Division, Lautoka. So basically, we were just doing the divisional hospitals in Fiji, and we couldn't travel out of Fiji due to the closure of borders. However, we've been communicating with some countries requesting this training, and these will be our targeted countries for 2021. Tonga, Niue, Vanuatu, and Solomon Islands. Yeah, however, some countries, due to lockdown and closure of their borders, they are willing to offer their qualified microbiologists to do the practical components on our behalf, while other countries, Tonga, Niue, and Solomon Islands, they really want us to go in country when borders are open. Thank you. Next slide, please. So these are some of the activities that we've been doing and following the training curriculum that was established by SBC and its regional partners. So these are some of the participants, as you can see, from Cook Islands. Yeah, it involves a lot of a mixture of healthcare workers from laboratory personnel, IPC nurses, clinicians, public health nurses, and pharmacists. So the morning session was mainly presentation, while the afternoon session was purely practical strengthening activities for laboratory personnel. Then the other members of the team can return to their individual schedule of work and join us the following day. Next slide, please. So during week 1 of the training, most of the practical sessions that were conducted were strengthening their quality assurance, media preparation, how they document quality processes that are implemented in media preparation or biochemical testings. And the important aspect of the training is that we were able to provide countries with ATCC strains. So it's a bit of a problem with most Pacific Island countries, as they could not get these ATCC strains. So it was one of the highlights of this training is that the benefit was that at the end of the training, they were able to isolate the ATC strains and then store them at -70°C. Part of the training component as well during the end of week 1 was the practical spot theory and practical exam. So each participant were assigned to different sites or stations, and they have to answer practical questions and theory questions that follow on with the practical questions. So from reading of cultures, identifying of pathogens, and reading of sensitivities, and identifying MROs. These were the core component of these practical sessions. And participants were assessed at the end of the practical exam, sport exam. Next slide, please. The core component of week 2 was the antibiotic stewardship. And as you can see, this was usually presented during a lunch hour session, and all the clinicians would be invited. And Dr. Eka usually conduct this session with the IPC advisor, SPC IPC advisor. And it's really a very important forum during this presentation, because it created a lot of discussion around strengthening antibiotic stewardship in countries. Next slide, please. One of the other core highlights of end of week 2 activity as well is for laboratory personnel to present case study relating to microbiology, identification of pathogens from real clinical samples. And they have to present it and then discuss all the quality assurance and how the challenges that they face during the identification of these pathogens, whether it's be MROs or other clinical pathogens that they've isolated and identified. Okay, next slide, please. One of the assessment activities that we do for all participants was to monitor the pre and post test, and these are offered before each presentation in the morning. So they do a pre-test in the morning before a session is presented, and then they do a post-test after the session has been delivered. So in this way, we were able to measure the change in knowledge of participants from before and after the delivery of a presentation. So this is a typical example result of the pre and post test from one of the countries from Cook Islands. And most of the time there was an improvement in the post test, which is really good. Next slide, please. We also monitor the sport exam that we conducted to laboratory personnel, and this is highlighted in this slide with their pre and their percentage of marks gained during the sport exam in Lambasa in Fiji. And IPC as one of the core component of this training program as well. These are the result of their pre and post test, and then the IPC activities that are usually conducted is really important for laboratory personnel. A review of the donning and doffing of PPEs. So this is one of the activities that were conducted by the IPC trainer to all participants during the training. Next slide, please. So these are some of the challenges that we've met or encountered during the delivery of this training. Now with border closure, we cannot go in country to conduct practical trainings, and hopefully countries who have opted to have their own qualified microbiologists to mentor their own staff will be working in line with our curriculum, and hopefully they should be able to deliver these practical sessions in their own countries. We've found out also that amongst the countries that we've done the training in, laboratories are having great difficulty in transferring their sensitivity data into an interactive antibiogram. and we've been asking support from WHO, and probably Doherty can assist us on this issue as well. We've also seen that there's a weak drug therapeutic committee in countries to monitor prescriptions and resistance of pathogens. And we've encountered this in Lautoka, where one of the issues that they were facing, pharmacists, especially with prescriptions that are not closely monitored, especially with sensitive organisms, and giving and being prescribed with other drugs that are being normally not tested within the lab for their sensitivity results. Next slide, please. I think this is the last. These are some of the references used in this presentation. So that's all from me, and thank you for all your attention. Thank you.
Thank you, Tabuka. Thank you for a really wonderful overview of a lot of work that's been done. I'll invite, are there any questions anyone would like to ask of Tabuka while we have him here? Otherwise, I guess I just want to take the opportunity to really thank the terrific group of people who've stepped forward to contribute to this forum. It's been really delightful, and for me, fabulous to see the different ways in which different groups like WHO and SPC and the Fleming Fund are all approaching a common issue, and really thrilling to hear from some of our fellows who are already stepping up and showing terrific leadership, and we can see that they will be leaders in the AMR space, and they really already are leaders in the AMS space in their own countries. So I might take this opportunity to bring things to a close. Thank you very much for your contributions, everybody, for a really terrific session, and we look forward to the next one happening later this afternoon. Later this evening. Have a good afternoon. See you later.
Thanks, Kirsty. Thanks, everyone. Thank you.